we quickly go for a relatively topic we need some thoughts, that is hepatic encephalopathy. So we'll cover in few outline this way. So you can see the hepatic encephalopathy, one of the advanced complications, and more often once it develops, likely the another 40% will develop recurrence in 1 year. And if you see a patient once have a hepatic encephalopathy, the readmission is close to 1/3 or 1/4 because of the indications of any liver related, and majority are being hepatic encephalopathy. And once this hepatic encephalopathy happens, the mortality is too high. 1 year mortality is 50%, and 3 years in absence of transplant is only 25%. And it is a brain dysfunction because of both liver insufficiency as well as the collaterals causing the toxins injuries. But at same time we have to rule out the whole basket of neurological psychiatric diseases which are common for any person, and liver patients are not immune to that. So if you think of hepatic encephalopathy, the grading has a big impact. You can see here, if a SLA person coming with a grade 3, the mortality is close to 80%, and any new onset has a very high in absence of a transplant. So if you think of the hepatic encephalopathy for this, the minimal hepatic encephalopathy also had a reduced survival. As we discussed, the mortality close to 50%, and the diagnosis of hepatic encephalopathy to the duration has shows a significant in relation to the MELD also, because MELD has not taken into account the hepatic encephalopathy. But you can see here, if a MELD is more than 15 and hepatic encephalopathy is long standing, then it is poor outcome. And here is very interesting is each episode, if a person of hepatic encephalopathy you are managing in your clinic lasting for more than 48 hours has a poor outcome than who is getting recovery. We see most of one hepatic encephalopathy recover overnight. And if they have a MELD score more than 15 and even they are admitted for a single episode, the hepatitis lasted for 2 days, they are a very sicker group patient, he should be considered early for the transplant. Then if you think of ascites as a combo, which most often we see, it causes more mortality. You can see it, if you only moderate ascites, the mortality shoots up. When you go for the both ascites and hepatic encephalopathy, even at a score of less than 20, even less than score 20, the ascites and hepatic encephalopathy both are not included in the MELD score, and they increase the mortality high even those than the MELD score than 40. So this is how this MELD score, as rightly discussed by my previous speaker, ascites and hepatic encephalopathy two are additional factors causing poor mortality. So that is not the only thing. When there is a hepatic encephalopathy, it is a disease of affecting the whole surrounding for them. It is surrounding patterned by the, you can see here the family and the caregivers. So when hepatic encephalopathy happened, there is a quality of life compromise that causes more problems than the disease per se. So how this hepatic encephalopathy happens? So before considering hepatic encephalopathy, you can see that this is a disease of brain dysfunction. So these brain dysfunctions can be because of hyperammonemia, because of systemic illnesses. We have to identify what is brain dysfunction, then you move to hepatic encephalopathy. Then if you think it should be a broad that all patients coming to you. So once a person has diagnosed to have a cirrhosis, and hepatic encephalopathy is a diagnosis of exclusion when you rule out other causes. In that you need to think of causes contributing to like liver failure, portosystemic shunts, nutritional related, electrolyte imbalance, precipitating events, drugs, and so lot of things are there, and the sole purpose of these products is to cause a inflammatory milieu. They cause a gut pathological translocations, there is a inflammatory stress and hyperammonemia, both causing to a development of this disease. And once this disease starts, the majority organ is the dysbiosis, then the systemic inflammation, neuroinflammation, and oxidative stress, which leads to the cognitive, memory, and motor functions. Either they represent as a overt or a covert hepatic encephalopathy. And when you go to the brain, you can see there is astrocytes are the major chunk to receive the burden because of the ammonia and glutamine conversion. Then the neurotransmitters, the GABA is a depressing, that you can say the mood is off, glutamate is got a mood off on. That means these patients can be excitatory or inhibitory neurological complications, which we see often because of this cytokine storm. Then next comes ammonia. We thought most inclined ammonia is synonymous to hepatic encephalopathy. Is not actually. When ammonia is high, it suggests or it corroborates your diagnosis. But if clinically thinking of hepatic encephalopathy, if ammonia is not in most studies to correlate to the level of hepatic encephalopathy. And at the same time, we have shown from the SLF, there is a ammonia level cutoff. The sick patients, if ammonia is remaining above more than 175, they are likely to have a poor outcome irrespective of hepatic encephalopathy. If hepatic encephalopathy, that is 1. If ammonia more than 175, that persisting on admission day 4, day 7, this is also high thing. So ammonia has to be taken case to case basis. Then how to assess hepatic encephalopathy? I think the house is aware of these minimal and the overt encephalopathies. But here we need to know most important is the psychometric, neurophysiologic and clinical examinations. And most important, the hepatic encephalopathy typing. You can do type A, B, C, that guides you for the treatment. A is acute, where the different treatment. B is for the bypass or the shunt related. C is liver synthetic dysfunctions. And you know, grading calculates your severity. And then overt or covert, that is because most of the covert, nearly 80% converts to the overt. And most important is another one, episodic, recurrent or persistent. If you persistent, has to go for early transplant. Recurrent, you find some other cause of precipitating, but has to go for the transplant. Episodic, you may manage for some time, depends upon the clinical and liver disease parameters. And next important is whether it is spontaneous or it is precipitant. That is, these three things give you guidance for a treatment planning. So if you go for the hepatitis evaluation, we need to know multiple factors. You can see here, this person is having to be considered as a good, bad or more by the combination. Either it is a severity of liver disease, associated comorbidity like we discussed the kidney failure, age more than 65 has a poor outcome, hyperammonemia to some extent is there, if is severe inflammatory stress or advanced liver disease can be there, and also type of precipitants that guides you to therapy. As we discussed, nearly hepatic encephalopathy, close to 100% will have some precipitate events. We need to know what are their precipitations. This is a very interesting study. The precipitation like infection, constipation, AKI, drug-induced GI bleed, hyponatremia, or non-taking the rifaximin or zinc. So when these parameters are commonly we see routinely, and this interestingly they have combined that how many factors are there. If risk factor is 1, 2 or 5, the more is the risk factors, the survival is so poor. So whenever we see a hepatic encephalopathy, try to find out the precipitate factors that will guide the therapy, as well as that will prognosticate the number of factors are there. Then another important is the SIRS. Presence of SIRS is associated with a poor outcome in case of hepatic encephalopathy patients. And as you know, the SIRS has 4 components. The more is the number of components, that is also proportionally correlated to the having a severe poor prognosis in case of hepatic encephalopathy. Then you think of, now we discuss the hepatic encephalopathy, its implications, when to go for the transplant. I think if you are aware of this minimalistic criteria, it shows that these patients, if survival chance is less than 1 year, we should go for. So these are the indications we very much aware. However, this minimalistic criteria is applicable to the all cadaveric setting of the patients. And just see a simple way, if you have a cirrhotic patient, his survival, likely median survival is 9 years. Any decompensation, the survival drastically down to 2 years. If SBP, it is less than 1 year. If hepatic encephalopathy, weeks to months. That means it is the disease which decides that how rapidly you should take action. And that is why the global consensus for the early referral for the transplant, be it the ASLD, it is the ESL, they think because the transplant is going to make a life-saving, improving the quality, and has now the improved outcomes. As already I am not going to talk on this, but here the MELD score has added all these factors but negates the hepatic encephalopathy, which are important factors. That means we have to consider patients with low MELD or beyond MELD. And that is why this is the which I am lucky to be part of this APASAL guideline and liver transplant, where these are the class taken the MELD indications as the exceptions to be considered for the transplant decisions. Then most important is the what is the challenges. You see here, do we need to see for a patient, the family and the healthcare system. The hepatic encephalopathy is as much they get delayed, the challenges get more worsened. And there is no support system for them to get a how they can get prioritized. And because of this, you need a challenge both for the disease, both for the social and for the systemic. And as we need their patient to be transplanted, need a optimization. So I have got quickly. So one of the important correctable factor is the portosystemic shunt. You can see here, if you are able to do a very early, that is child A, male is 6 to 9, they have a good outcome, you can offer them a shunt closure. And it is very interesting that the shunt percentage also increases as the severity disease increases. If a child C, you can get 70% having shunt, where you cannot offer any therapies. So, and very interestingly, the more is the number of portosystemic shunts or the collaterals, then the more is the hepatic encephalopathy and poor is the transplant survival. So that is a correlation to them. However, very early stages, they show a good transplant-free survival for this group of patients. But obviously, it is not without complications. When you shunt closure, then the varices become increased, they develop worsening of ascites, and I think you have to select a few group of patients who have been low MELD, but transplant evaluation should not be made, that is not needed. It should be there and you have to counsel, and also low albumin is one of the poor factors. Then when a patient comes to us in critical care setting for the hepatic encephalopathy, particularly in SCLF or ALF setting, now CRRT and ammonia reduction has shown some improvement in the cerebral hemostasis, cerebral edema, and the hemofiltrations also has been added with filters to reduce the cytokine storm that can indirectly help for the ammonia reductions. And as we discussed, the filters are now changed from hemopiltration DP mass, so they are also giving help to these two patients who are sick. I think everybody is aware of giving the LOLA. LOLA has been verified for the ALF, but now meta-analysis is coming up that it is to some extent helpful for the prevention, particularly those have a recurrent or persistent hepatic encephalopathy. Similarly, now this is a new drug has come up, phase 2, that is SLOPA, just ornithine phenyl acetate. So this is interesting in that the ammonia reverse cycle is blocked when there is a LOLA, there is a channel is open. Hence, complete utilization of ammonia, rebound hyperammonia is poor in this drug, but still it needs to be approved for the FDA. Then important is the rifaximin. We know rifaximin, even we give lactulose as the first line therapy, we have a chance of 75% with rifaximin, close to 1/4. Even with combination, we are getting more of recurrence. So what is the overhead? So this is a very interesting study. What they have done, they have shown those patients who have done the rifaximin and they are responders or non-responders. They are microanalysis from these two organisms, salivarius and nervous, and they have found that when you combine them with the secondary bile acids, like the deoxycholic acid, then you can find it's not UDCA, the deoxycholic is not, few companies are available. So that is a good food for thought. If rifaximin we are giving, still getting a recurrence, we can get secondary bile acid related salts where we can get a clue to benefits. Then next important is comes the gut microbiota, which is the main organ for the hepatic encephalopathy as well as the liver disease complications. The concept is that this is a rough soil, you populate with a good soil. So when soil is good, the results will be good. So hence the concept of having the gut microbiota modulation has come up. And it can be an antimicrobial therapy like rifaximin we are giving as the focused one, probiotics which is just like to empower them, or we can go for the FMT which is like the Hanuman, we taking the whole microbiota to be replaced. So this is the interesting trial come of the thematic trial where they have given FMT along with capsules to this group of patients. They found that there is no improvement in death or transplant. However, they found that hepatic encephalopathy recurrence can be reduced, liver related admissions are decreased. So in a patient of cirrhosis, child C, hepatic encephalopathy once, FMT can be given for 5 days, and this has helped in that way. And they have shown the recurrence is on the lower side, particularly when giving both enema as well as the capsule groups. Then probiotics, which is most widely used and few debates. So I just brought a meta-analysis where they have showing that it is not helpful for liver related complications. It is only helpful for the prevention of hepatic encephalopathy in these groups. And recently interesting one that we are very much used to write a PPI. So this PPI has a poor outcome as far as the meta-analysis is concerned. This suggests that these are causing aggravation of the hepatic encephalopathy, because we thought of there is some debates is good or bad, but this meta-analysis is good. I think taken good number of around 12 studies. that try to avoid PPIs in your hepatic encephalopathy patients as far as possible to prevent hepatic encephalopathy. Then important is the long-term albumin. I think everybody aware of the established indications for albumin. So this is hepatic encephalopathy, hyponatremia, SBP are coming as the doubtful indications, and obviously SCLF, muscle cramp, these are coming as the emerging indications. The concept is that to totally modulate the albumins where it acts as anti-inflammatory, it helps in the cytokine storm reductions, and also it corrects the hyponatremia. So combining these, it can help the spectrum of hepatic encephalopathy long term. However, the cost benefit analysis needed. Then next is the what is the challenge? It's a very interesting study across 1400 physicians across the Japan. This shows that the peoples are not able to diagnose hepatic encephalopathy because of lack of a good modality. If you think of the gold standard of hepatic encephalopathy, it takes around 30 minutes, which is difficult to assess them and not able to identify the parameters. And then these peoples need to be treated. Just to conclude my talk, hepatic encephalopathy in a critical ill patient needs to be considered to be admitted to the ICU. They need a speed for the acute insult. They need to manage for the precipitating factors. At the same time, calculate the disease severity scores. Then they need a early transplant listing. And at the same time, you have to give all the therapies, give a response guided therapy, so that the critical period, the first week, is the golden window where we should think of a decision how to go for. So just to summarize my talk, cirrhosis needs hepatic encephalopathy associated as to go for LT. Pre-LT optimization needs more than rifaximin, albumin, nutrition, muscle mass, gut modulation are needed in multimodal way. Correctable cause like shunt closure, other disease, particularly for the brain related, has to be excluded before considering a case as hepatic encephalopathy. Thank you.
So, excellent discussion, sir. Covered almost pathophysiology and precipitating factors and almost treatment till now. So I have one question, sir. In patients pre-transplant, suppose shunt-related hepatic encephalopathy or episodic encephalopathy because of precipitation by some infections, is there any challenges in post-transplant? Because post-transplant, lot of immunosuppressions and intubation, post-extubation, is there any delay of extubation? Is there drug-to-drug interactions?
Yeah, so very right, because number of slides have not added. So now it is come as a functional MRI concept. So any persons of hepatic encephalopathy pre-transplant, you go by the functional imaging of the functional MRI. You can identify the pick-up areas, metabolite patterns, and they suggest that those having a long-standing hepatic encephalopathy, prolonged or persistent hepatic encephalopathy, a recurrent episode of hepatic encephalopathy, a reduction in the frontal and temporal lobe areas, and then I forgot some metabolite changes are also there. If these are there, they are the poorer predictors, and these people are likely to be more in terms of getting therapy related side effects much faster. Tacrolimus related, sodium fluctuation related, they can get more symptoms. Second, even there is not symptoms also, their residual neurological deficit remains nearly around 70% for 5 years, there will be more. So definitely pre-transplant neurological disease has a implication for the post-transplant outcome, and I think now the things is coming up that we should include functional MRI, not a plain CT of the brain, functional MRI, particularly for the hepatic encephalopathy patients. So that will help both the ways for the during peri-transplant period or long transplant for a neurological perspective.
Any questions from audience? Thank you, sir.